go through the housekeeping. So as a second generation settler of color, I am grateful to acknowledge that I live, work, learn, play, love, and create on the traditional, ancestral, and unceded territories of the Coast Salish First Peoples, in particular, the Stolo, Katsi, Kwantlen, Kikite, Semiahmoo, Tsawwassen, and the Musqueam, Squamish, and Tsleil-Waututh territories on which the offices of Pain BC are also located. So this being a national, or perhaps even one day international conference, we are gathering from many places. And so if you know the territories on which you live, we invite you to share this information in the feed loop chat so that those too can be honored and acknowledged. So as I said, I've got a bunch of housekeeping notes to cover before we begin our program for today. So you'll just have to bear with me for just a few minutes longer. I will add that most of the housekeeping information can be found on the lobby page or the session pages for your future reference. So today, which I'm very excited about, we have two sessions here, probably about an hour each. First of them is a conversation about equity in pain with Dr. Dassieu and Therese Lane, then a 1 hour break, and then a stand-up comedy session featuring comedians who live with pain, headlined by one of our own steering committee members, Desmond Williams, and joined by his friends, Megan Milton and Jenny Russell. Super excited. Now, during the 1 hour break between the sessions, there is also a 30-minute optional guided gentle movement session led by Neil Pearson. So Neil Pearson, apart from being an overall awesome human being, he is a physical therapist, a yoga therapist, and an author who specializes in pain research and working with people living with pain. This gentle movement session will show different levels of movement for all abilities. So we hope that you'll join us here and show up where you're at. You can find the gentle movement sessions in the sessions tab on the left of the Feedloop homepage. Another exciting option during the break is that we have a full hour in which you can join your peers in discussion in breakout rooms, or what we call water coolers. And we'll have different ones available throughout the week. So for today, we have two breakout rooms. One of them is on the discussion topic of strategies to cope with pain or life hacks. And the other is a general water cooler session for whatever you wish to talk about, where Pain BC Support Services staff, whom I totally love and trust, will be available to connect with. Wherever you end up, we hope that you take the time to gather and meet and mingle in a way that is engaging and meaningful for you. So the water cooler sessions also can be found under the Exhibit Hall tab. Also in the Exhibit Hall tab is Alex Hagar's slides from their presentation describing your pain to clinician. It's already up, so that's fantastic. Closed captioning, as I said, is available through Feedloop and to viewers who join the session through Zoom. So you can turn this on by selecting the CC button at the bottom of your screen as a viewer, and then you can select the language in which you like these captions to appear. Please remember that the conference has been designed for and by people living with pain. And so while it's important that we have it open to everyone, we've also done our best to design it to create a brave and a safe space for people who live with pain. And while we definitely hope that there are researchers and clinicians who are here to also learn, we ask that you please spend your time at the water coolers listening to people who live with pain, rather than using these spaces for research or other purposes. I also wanted to bring your attention to the resources page we've created, which you can again find in the Exhibit Hall tab, excuse me. And it is a national resource list for people living with pain, and which was compiled by, again, the awesome Pain BC support team. So check that out as well. And again, we want to acknowledge that stuff may come up in conferences like this, in movements like this, where our intention is to create, as I said, a brave and a safe space, especially for people living with pain. So that could look like physical discomfort or emotions and memories, pain. So we encourage you to take care of your needs. So if that means that you have to take a break, lie down, go outside, look out the window, leave the conference altogether, then that is good. That's more than okay. Because all of the presentations, with the exception of the water cooler and the gentle movement sessions, they're all being recorded. So you can come back to the presentations in the future, when you're ready for them. I know I will, for sure. So thank you for reaching out with your questions, your comments, and your stories. I hope you continue to do so throughout the rest of this week. Again, check out the lobby page for more information and continue to explore the Feed Loop conference site as a whole, especially with the networking opportunities, because we will continue to add and modify content in response to your feedback. Whew, finally, I would like to thank the conference's sponsors, Pain BC, the Strategy for Patient-Oriented Research, otherwise known as SPORE, the Chronic Pain Network, the Canadian Institutes of Health Research's Institute of Musculoskeletal Health and Arthritis, and the Partnership for the Engagement of Patients with Pain Research Project, otherwise known as the PEPPER Project. So information on about our sponsors can be found on the page header at the top of your screen on the top right, and you'll see it scroll through. You'll be able to click on those links there. Okay, so our first session today is a conversation about chronic pain and equity between Dr. Dassieu, who is a researcher on chronic pain and substance use, and with Therese Lane, who is a person with lived experience on the intersectionality of pain and other marginalized communities. Both of these extraordinary women are deeply committed to improving access to care and services for people living with pain, and especially for those who are most impacted by social injustice. So we'll have some time at the end of their conversation for Lise and Therese to respond to your questions. And you'll notice, especially if you're in Zoom, you'll notice that the chat function has been disabled, and that's because to minimize distractions for our presenters. You will, however, have the opportunity to ask questions. Only two. You can ask questions and make comments in two different ways. Yeah, one through the Feed Loop platform chat, which is on the right when you see the live stream, or the second, if you've joined through Zoom, you can do it in the Q&A at the bottom of your screen. I also want to assure you that your questions are monitored in real time and will be moderated in this session by the amazing Don Richards, who you'll see later at the end of the session, who I would say has been the engine for the steering committee and overall committee member herder. So without further ado, I am excited to turn this over to you, Lise and Therese. Welcome.
Thank you, Jenny.
Thank you very much, everyone. I'm so excited with this event. And many thanks first to Dawn and Therese for inviting me. I'm really honored to be part of this conference led by and for people who live with pain. So we will start this discussion about chronic pain and equity. Maybe I let Therese make some of a first introduction.
I'm not sure, can you hear me?
Yes.
Okay, because I had a message from Chiasha saying that I'd lost the sound. Okay, good. Yeah, so I think I wanted to just say why I thought you were a great fit for this conference. Not everybody can see. I live in downtown Toronto, and there's a lot of people who are homeless, live in shelters, and you can't help but notice how they walk. They're hunched over. They're living with undiagnosed pain. They're in a lot of pain. Their lives are in chaos. And I know because I've been there. I know what it's like. And my heart goes out to them because the treatment for pain just doesn't reach them. And when I was moderating your panel at the Canadian Pain Society, I really felt that you understood these people like myself, and that you wanted to do something about it. And to me, that is why you're here today. And I'm looking forward to us chatting once you've done your presentation. And I'm sure everybody's going to love your research and how sensitive you are to this subject. Thank you, Lise.
Thank you so much, Therese. I'm really blessed by what you just said. It's really, I'm happy if I can help, and I hope everyone here will also be interested. So, just how we were thinking about this presentation. So first I will share some of my research projects and some research findings. I will really try to make it short, because I think the real intention of this session is having a dialogue between research and experience. So really thinking together about how to improve equity for people who live with chronic pain, and also how to reduce stigma. And so I really want modestly to share some research findings that can be a way of starting this discussion. So I will start now with the research piece. So I will briefly present 3 qualitative research studies that I conducted in my previous role in academia as a postdoctoral researcher at the University of Montreal and at the University of Sherbrooke. And I want to specify that today I'm speaking on my own behalf, and this is not really related to my current researcher role. This is qualitative research. So for those who may not be familiar with this approach, so it really doesn't involve numbers, statistics, or many things that we are often seeing in research. So qualitative research is really about having long discussions with people. So me and my team have been meeting with people who live with chronic pain during in-depth interviews. So interviews can last 1 hour, 2 hours, really depending on what people want to share. And we really wanted to know more about their experiences in an open discussion. And really one of the goals of all this project was to give voice to people who have lived experience. And also to use some sociological context, because my background is as sociologist. So using sociology also to understand chronic pain as a social experience and not only a medical or a psychological one. So the first project was about chronic pain experience and management among people who use illicit drugs in Montreal. The second one is an analysis of the social impacts of the opioid overdose epidemic on people who live with chronic pain in Quebec and British Columbia. And in the third one, we examined chronic pain experiences and inequities during the COVID-19 pandemic across Canada. So I have been leading the qualitative components of this study, but I really want to highlight that I was not alone doing this project, and I conducted with a team of researchers. And so I really want to thank all my colleagues for enabling this project, and especially Professor Manon Chouanière from the University of Montreal. So first, this research highlighted really the painful lives of people living with chronic pain in socially disadvantaged contexts. It really showed how social living condition can influence the chronic pain experience in its onset and its evolution as well. And the physical and the social are often closely intertwined. So some difficult living and working conditions can be really fertile ground for chronic pain. And we observed that for marginalized people, especially those who use drugs, social living conditions such as living on the streets can really lead to physical pain and also poor evolution of this pain. And in the context of marginalization, pain is often not central in the person's life, because often people need to prioritize other social issues or other health issues that are really related to their daily survival. For example, housing issues or threatening health condition. So it really leads to direct impact on their clinical trajectory for chronic pain, because this social condition can prevent them from seeking care, and their pain may get worse and remain unmanaged. So this is below the reference of the article you can find about this study. And if you don't have access to a journal article, please reach out to me or to the conference organizers, and I will be happy to share a copy with you if you're interested. So the second, another aspect that we studied, I see the arts in the screen, it's great. Another aspect we studied was how social relationships can also shape the chronic pain experience. So to illustrate this point, I will refer to our study of chronic pain experiences during the overdose epidemic, because we analyzed how the overdose epidemic impacted social relationships with friends and family for people who live with chronic pain. So first, participants reported frequent experiences of disbelief and lack of support from some of their surroundings. And chronic pain is often an invisible disease, which makes it difficult for others to understand, and especially to understand chronicity, that the pain will likely not stop soon. So this is something people had trouble communicating about. And participants also reported that it was often impossible to talk about pain and opioid during the overdose epidemic, because they faced diverse manifestations of stigma and discrimination in their daily interaction in both personal and professional lives. So the consequence of these stigma experiences is that people with chronic pain often need to deploy a lot of energy to counter stigma in their daily interaction. And we used the concept of advocacy work to describe how people with chronic pain constantly needed to advocate for themselves, deploy some communication skills, some education skills to explain their experience to other people and also to healthcare providers. And I see you had a workshop about this yesterday, and I think it's great. So this advocacy work can be challenging. It is really a burden that adds up often to physical pain. And our study shows that this has been intensifying during the overdose crisis because many people have now heard about opioids and pain from the media. So participants had to constantly explain why they use opioid and why they needed it to manage their pain. And to avoid the burden of this advocacy work, many participants reported that they preferred concealing their pain because they anticipated stigma or misunderstanding, and they often felt powerless in changing other people's opinions. So this could prevent them also from getting the help they needed, and this could sometimes lead to social isolation as well. Yeah. And so another aspect that participants reported was about interactions with healthcare providers and issues in accessing care. So you already, I'm sure you already know all of that, but many of our participants said they faced some disbelief when seeking care. This was reinforced during the overdose epidemic because of the media coverage, and people reported care denials and labels of drug seeking, especially for those who were using opioid. And they also reported more positively that having a trusted healthcare provider really made the difference in their ability to access care and to be believed for their pain. But as the participant notes, unfortunately, not everyone has this chance in the current state of the healthcare system, and it can take time to build a relationship of trust with a physician or a provider. And also those who had least financial means, especially those who do not have a health insurance, they also highlighted that they could not access physical treatments such as physiotherapy, which is often essential for pain. And for some, this meant that self-management was the only way to deal with their pain. And finally, the last research I would like to share with you is about social inequities and chronic pain during the first stages of the COVID-19 pandemic in 2020. So we noticed two forms of social disparities that were intensified by the pandemic. So first, people living with chronic pain and belonging to minorities, they experienced intensified impact of COVID on their physical pain, but also on their access to pain management, their mental health, and also some economic challenges. And the pandemic and chronic pain were often, they had often some accumulating effects for members of equity deserving groups. And second, a finding that was somewhat surprising, but not so much if we think about it. Many participants reported some positive experiences during the pandemic in 2020 due to the general slowdown of society during the first wave. You would appreciate that it may not really be the case now, but they really felt that it was this way of living was more adapted to their chronic pain condition. And one participant even said that the pandemic slowed the world down to my pace. So it was really a big change. And I think it highlights the lack of social inclusiveness of people who live with pain in the pre-pandemic normal world, especially regarding the social injunctions of being performant, being productive, being always active. So these were, during the first wave, this was suspended, and some people had positive experiences due to that. So I think I'm done with the research part. So now Therese and I will start the dialogue by asking each other some question, and then in a second step, we will open the discussion to the audience. So maybe I can stop sharing now so we can see our faces, right?
Thank you, Lise. That was great. I think I identified with every part of that. I know you and I have talked, but there are a number of things that brought my attention. I think it's slide 5. I'm not sure where it says sometimes pain has to go backstage because there are more important things to deal with that day. And those change on a daily basis. As a person who lives with pain, as a former drug user who lived on the streets, my life was chaotic. And some days I just didn't know how my day was gonna pan out, what was gonna be more important. And I was by that point, I had, my self-esteem was shot. I didn't think I deserved treatment, so I didn't talk about it. And I didn't think anybody would believe me anyways. And I'd always have to advocate for myself, and that I wanted treatment for me, for my pain, but I couldn't get it because they just thought I wanted drugs, I guess. Nothing else. I wasn't validated. And I think all these things, I really feel that you've captured them. And I'd like to know how you went about accessing this kind of information, because you seem to have captured it.
I think I'm not doing most of this. The participants in the research were really guiding me, and maybe the value of doing such research is you can access several experiences of different persons. So people, because when you're only one person, you can feel that you're alone having this experience. And while doing the research, we see that some experiences are very common among people, and really social experiences. But the researchers, we are not the ones doing this. We were just uniting different the words of our participants, and maybe highlighting these trends. But and how I came to this, I think that during my first research project, I was working with people who use drugs and their access to medication in France. And pain was always present in their, all that they said, because they could use some drugs to relieve pain sometimes, or self-medicate. And so really I had a lot of interest in pain management, and also how people are working on their own pain management, and how they can really find ways to get better without if the healthcare system is not helping, how people are finding ways to have more positive experiences. So yeah, I'm not sure I answered your question, but
yeah, you did. And I just like to know how you gathered. Did you talk to your participants, or the community? Did you talk, or did you feel you were in a position to talk?
Mm-hmm. So I think my position about this is constantly evolving. And so the first work that I did, I was doing the interviews myself, and in some projects some members of the research team were doing them. But now what I'm starting to see also in the work I'm doing now is that having people who have lived or living experience really conducting the interviews themselves can really be an added value to the project. So having peer researchers, because it's also creating a safer space for participants to share their experiences if they see that someone is having the same experience. So now what I really want to do is really partnering with people who live with pain to do research and really involve them in the process of collecting, analyzing the data. I think it's really important, and this is really the way to go. So I really hope that partnership initiatives will really be more and more common in research in Canada. So yeah, this is my evolution.
I think that's great. I think that Minister Bennett touched on it yesterday when she said nothing about us without us. And I think that really resonates, and people are willing to help and give their share their experience to further research, and I think it only makes research more genuine and superior, actually, because you put it as a patient partner or somebody involved in research, you're putting a face to the research. It isn't just all done in a lab or behind closed doors with a bunch of people who read books, kind of thing. Not to take away from academia, but we all have our place within research, and I think every day that is being shown. And thank you for coming to that realization.
Sure, and yeah, the nothing about us without us should really apply to research, I think. And yeah, it's really, it's best for everyone. It's best for research, it's best for participants, and it makes really research more aligned with the needs and the preferences of people who have lived experience, and we are doing the research for you, so you should, people with lived experience should have a say on what we are doing. And Therese, I had some questions for you as well, because as you said, it's important for me to make research that is significant. So I wanted to maybe have your opinion of what are your hopes for the future, and how do you think that research can help, and how could we make sure to do research that will be relevant for people who have lived experience of chronic pain?
I guess I am kind of hopeful for the future, and in that I think that I think that researchers need to look at this state of the healthcare system. They need to acknowledge that the inequities are there, and they need to be more in touch with what people want as opposed to what they want. I'm really not sure of, well, I went to a meeting one time and I had the full account of how research happens, but on a more layperson's terms, I think that they need to see what needs to be done. They need to get people with lived experience right from the start. And I think that going forward, that it's going to fill a lot of gaps. The right people will get the treatment. Hopefully research doesn't take 17 years from being completed into being implemented. I'd like to see that, not like a thing of the past, but yeah, I just think that people need to be involved, and there's enough people with lived experience that are willing to do it. I don't know what else to say.
Yeah. And as you said, time can be a challenge because sometimes the timelines of research are not the same as the emergencies that we face.
Yeah, but I don't know, I don't see why, you know, some things can't be quicker. I mean, look at how quick things were done during the pandemic. Bills were passed overnight, and, you know, sometimes they take months and months and years to, so it can be done. I think the fact that the minister related yesterday to and shared like her feeling of being helpless, didn't know how to treat people who lived with pain. And I think that, you know, coming from that level, I think that I know my own family doctor sometimes doesn't know how to talk to me. He'd like to. I think more training is needed with healthcare providers and first responders, and it would be great if everybody had their own family doctor. And I think that stigma needs to be lessened in the ER. I've noted for myself, I've noticed that if living on the street and being an addict in pain doesn't kill you, that the judgment approach will be with you for the rest of your life. I mean, it's years since I used intravenous drugs, but I had a pain at the beginning of the pandemic that was different from what I experienced from my chronic pain. I knew it was different. I was feeling different. 4 times I went to the ER to try and get somebody to even give me a blood test. And it was just, I was just judged right there. And this is years later. And the only reason, somebody did ask me how I was flagged, and I'm not flagged. It's just that because of past addiction problems, they thought for pain, methadone was the best treatment for me. And I've been on long-term methadone treatment. And I think the fact that, you know, when they saw that on my chart, I was just seen as self-seeking, and that wasn't the point. And by the time I did get a diagnosis, it was serious. I had osteomyelitis and a fractured femur, and I knew all along wasn't just arthritis. So I think those, and I knew that I'm not the only one who goes through this, that anybody, and sometimes you can't advocate for yourself too, because you're too tired. You just don't care about yourself, and there's so much disbelief, and I'd like to see all that change, and I hope it does.
Yeah, and I think one of the changes that needs to happen is really recognizing the knowledge of patients. As you said, you know when something is wrong in your body, you know it's not your usual pain. And this knowledge is really, it's really important, and it should be recognized really. So it's a matter of trusting people's expertise, and I really hope that there will be changes in this way in the medical field and medical training as well with chronic pain.
Well, I think that that's why it was important for me to invite you to this conference, because I could see that it meant that it was important to you, and that gives me a lot of hope. It really does. You know, I mean, I'm a grandmother now, and I have to think about what's coming after me, and if I can do something each day to improve that for my children, my grandchildren, your grandchildren one day, Lisa, then, you know, we have to we can never stop working towards a solution. And I think one day we will be more accepting of people. Got a long, long way to go, but it's possible. Nothing is impossible. I think we have to work in a solution as opposed to living in a problem.
Right.
Yeah.
Yeah.
But I find that, you know, even there was another slide about saying, explaining that we don't get better. Like even my doctor asks me, am I feeling better? No, I'm not feeling better. You know, I'm never going to feel better. And then I know I've gone into myself and just shut off the world and isolated because people can't talk about it anymore. And I think that that's a dangerous point. And I think that we should be able to talk about it. We should be able to talk about it without feeling stigmatized or judged for talking about it. And that people, if they're in pain, get treatment, get timely treatment. I watched my friend who was waiting for a hip replacement, could barely walk. And it was like, oh, maybe she had her doctor's appointment, her surgeon appointment, and it was going to be 18 months down the road. That's not right. And I'd like to see all that change. And yeah, maybe asking too much. I don't know. Ideal world. I don't know.
Sure, you're not asking too much, but yeah, you
Yeah.
have to ask.
Yeah. Yeah, no, but not everybody has that voice. And I think that I have a big mouth and a big voice. And this conference to bring attention to these inequities, and that I should use that voice. We all have a purpose. If I didn't have a purpose, none of my past experience of homelessness, living on the street, losing all my family and friends, makes no sense to me at all. So in the last 6 years, through working with people who are in research, I found out who I was. Far too late, I guess, in life, because I mean, I'm reaching my twilight years now, but I'm glad I did. And if I can help one person get through their day, then I feel okay about that. Yeah.
That's wonderful. I think for us researchers, it's great to hear something like that. If we can help empowering people like you, I really like that. And yeah, it's great. I don't have much to say.
No.
You said it all.
I don't know. Do you think we should open up for questions?
Oh, yeah, we have 15
well,
minutes left.
Yeah. Oh, wow.
I don't know if
Chatting
there's...
away here. There's Dawn. Hi, Dawn.
Thank you so much, Therese and Lise, for the wonderful presentation, Lise, that you provided on your research. And thank you for doing that important research. And Therese, I am so grateful and honored to call you a friend. And I learn so much from you every time we talk, whether it's about something as simple as baking or whether it's your life wisdom. And I just want to thank you for being who you are, because I honestly can't imagine a world without you. And I think you represent important voices that can't necessarily be heard. And I'm seeing lots of hearts and thumbs. And honestly, just thank you for everything that you do.
Thank you.
So we've got some questions, Lise and Therese, if you are good to answer some of those. Lise, one question and some comments that we got about that people didn't see in your research on inequities, that seniors were included, but maybe you can let us know if that was the case, or if you know of research that's been done specifically with seniors, given sometimes they're living in difficult financial situations. They don't necessarily have family or medical support. So could you just let us know if you've done research in that area, or if there were individuals that would be considered seniors as part of some of the participants in your research?
Yeah, sure. Seniors were included in my different projects, but yeah, I haven't explored this in particular as much as I should have, but in qualitative research, it's sometimes difficult to see what is the cause really playing out in something that we find out, because we have just a few participants, but for sure seniors can have specific challenges with socioeconomic issues as well, and of course, but yeah, about ageism in itself, I don't have specific results in my studies, I'm sorry, but I really agree that this is a population which is very important, because they have more risks of having chronic pain as well, and we should really investigate that more, maybe in future research projects, and I'm taking note of that, because people's suggestions are important as well, to know where to go with our future research. But yeah, I'm trying to think of examples, but sorry, nothing is coming to my mind now, but if I if I have ideas, I can make a follow-up if you want.
Thanks, Lise. I think if you do have examples that you could share, you could post them in Feedloop for the group, or we could do that for you after the fact. And Therese, I guess kind of along those lines for you, like, I mean, you're telling us that you've experienced all kinds of stigma related to some of your life experiences. Has ageism in particular affected you, or do you think you know, what you've experienced is a culmination of many things?
I think the fact that any kind of pain I have is it's just arthritis. And it's not just arthritis. It's not just wear and tear. There is genuine pain. Enough that it's slowing me down. It's enough that keeping me awake at night. And I say it's just something is it's so derogatory, and it is ageism. It really is not taken so seriously.
Thanks.
That's such a horrible fact, that is.
Thanks, Teresa. And this is more a comment than anything, but between, you know, yesterday's sessions and the discussion here today, I'm just continuously struck by the burden that I'll say the system or society places on people who live with chronic pain. We've heard this repeatedly throughout the conversation. And so I guess I would ask both of you, Lise, with your researcher hat on, and Therese, with you having lived with pain for many years, what would, you know, obviously politicians are listening, they're starting to invest. You know, what's your kind of prompt for them about how they can facilitate making things less of a burden for people who are already dealing with so much? That's a big question, I realize.
Yeah.
If you want to
Yeah.
think about it, you can. We've got more questions in the Q&A. I could come back to that. That could be your kind of parting words if you'd like.
Less stress on the family doctor, I think, that or the family physician, to have first points of contact being someone other than waiting for a referral from your family physician. Like if you think you need some physiotherapy, you should be able to contact a physiotherapist at your clinic. You shouldn't, and you shouldn't have to drive all over the place to do it and have a plan or anything. But you know, you have to wait to see your family doctor, and then chances are you don't have one anymore. And then you have to wait for a referral, and then you have to go on a waiting list. And I think all that needs to be dealt with.
Thanks, Therese. Lise, do you have any comments there?
Yeah, so we comment really from what participants in my research said, but I don't live with pain, so I'm maybe not accurate. But what I think would help maybe is the first step would be recognizing or acknowledging that this is a burden, and so not making things like it's normal, everyone can do that. No, it can be an additional burden when you have pain to just do things that can be easy for other people. So maybe educating and just recognizing the existence of this burden to first, this is the first step before maybe reducing it, but knowing that it's there, I think it's important.
Great, thank you. There's another question too. This is for you, Therese. Can you talk about your own journey of being involved in research as a patient partner and what that's been like? You and Lise talked a little bit about this here, and it sounds like we've led Lise to the water. She wants to start engaging people with lived and living experience. But can you share, Therese, a little bit with the audience about what that's been like for you, and maybe some of how that's benefited you or changed your perspective on things?
Well, I think it has helped me to focus less on how pain has taken over my life. I think that's taken. It's not that I don't recognize it's there, and I don't respect that part of me. It's just that I want to do something for moving forward. I want to make what my pain drive me. And I think that being involved in research and the people, well, more so the people who I've met while being a patient partner, that have guided me, kind of maybe not even knowingly, to a place where I'm comfortable with me today, and knowing that I have a voice and that I could do something about it today. And I've met some really amazing people. I've met some of the greatest minds in research, and I've met some of the hardest working people who live in pain this side of, I don't know, or the pond, I guess, I don't know. But and it's inspired me. It's inspired me to try to make a difference for people who are going through pain now and in the future. I mean, pain is not going away. It's always going to be there. And I would like to see more treatment for pain, more recognition, less stigma, less judgment. People can talk about it more, and anything I can do, I want to do. but I found my voice, that's for sure.
You certainly have, Therese. Don't stop using that. Maybe, Elise, this question is for you. Chris has asked this, and I'm going to condense it quite a bit, but the intent isn't to lose the context. But as a researcher, I wonder if you would be able to respond. Chris is concerned that the more chronic pain initiatives are aligned with substance use initiatives, the more the assumption is confirmed and spread through healthcare, increasing stigma and mistreatment. So I'm wondering if you can comment on that, Lise, or if you can comment on research that you know is happening outside of alignment with substance use.
Yeah, I think this is a really, really important issue. And thanks, Chris, for asking that. What I think is that substance use stigma is a big problem in itself, and maybe this explains all the rest. So I would really caution about making an opposition about people who have pain and who are legitimate patients for opioids and people who have a substance use disorder and are seeking drugs. This does not exist. It's often the same people, and really, we don't win anything in opposing people. Really reducing substance use stigma would be beneficial to people who live with chronic pain and don't have a substance use disorder as well, because this label, the drug-seeking label, or as you want to ask it really with with quotes, but this is what is damaging access to care for everyone. So of course we can separate both, but I think the main issue is stigma here, and we have to fight substance use stigma just like we have to fight chronic pain stigma. And yeah, I remember in one of my projects, some participants were really worried about being associated with people who use substances, but I think yeah, it's important to just not have the wrong targets here. I think yeah, I don't know to say that clearly, but I really think that everyone should have access to the care they need. Should they have a substance use disorder or not? This is not the question, and people who use substances will not take anything out, will not steal anything from people with chronic pain. I think, yeah, reducing inequities is really for everyone. So I'm not sure I answered the question really, but people should not feel threatened by that. The real issue here is stigma, I think.
Yeah.
Thanks a lot, Lise. So I see there's unfortunately still questions that we can't get to, but we'll see if we can find a way to somehow answer those for people. And we do have to wrap up. I really, again, want to thank Lise and Therese for the insightful session and for you being so honest and willing to answer basically any kind of question that came your way. So thanks very much. For those of you who are with us, we're going to take a 1-hour break before we have a painfully funny session, which is a stand-up comedy session of people who are living with pain. And in that hour, we've got a couple of options for you if you don't feel like stepping away. One option is for you to join the 30-minute guided gentle movement session, and you can find that under sessions in Feedloop. As Jenny said, that will be led by Neil Pearson, and Jenny and Desmond will also be helping demonstrate different ways to do the gentle movement. If you'd like to join a water cooler session, we've got 2 sessions on. One will be guided by myself, and it will be about strategies to cope with pain, or so-called life hacks, so you can share with others some of the tips and tricks that work for you. Or we've got just an open organic discussion water cooler session, and you can access those through the exhibitor hall, and there will be Zoom links for you there. So that wraps up our program for the next hour, and hopefully we'll see you at some of the sessions over the next hour. Or if you take a break, we'll see you back in an hour, and hopefully you'll join us to have some laugh therapy. So thanks everyone, and enjoy your break.